Hi, everybody. I hope everybody got some lunch. There's still more back there if you want seconds. I thank the program organizers for inviting me to speak today about how to develop a program to help patients around this issue of fertility preservation before cancer treatment. And as you all know, treatments for colorectal cancer can certainly affect fertility. Surgery, radiation, and chemotherapy all contribute to this problem. So specifically in males, certain chemotherapy drugs and exposure of the testes to radiation can destroy the spermatogonial stem cells, resulting in impaired fertility for many patients if they don't survive after treatment. Surgery and radiation to the pelvic area can damage blood vessels, nerves, and connecting ducts that are essential for erection and ejaculation. And so patients who have erectile or ejaculatory dysfunction may actually be producing sperm, but they can't deliver it naturally to their female partner. If we look at females, we know that certain chemotherapy drugs and exposure of the ovaries to radiation will destroy the eggs or follicles in the ovaries, and this can lead to a risk of infertility and premature menopause. And finally, for patients with rectal cancer who have to get pelvic radiation, the high dose of radiation exposure to the uterus results in fibrosis or scarring of lots of the tissues in the uterus, and so these women are not able to carry a pregnancy after treatment. Now, there are a number of options to preserve fertility for patients with colorectal cancer, but steps to pursue this all have to be taken before treatment begins. So for males, the standard approach is sperm banking. This is usually done at a freestanding licensed sperm bank or within an andrology lab of a fertility center. Patients collect specimens by masturbating. We generally recommend that patients collect 3 specimens to give them the best chance of having a biologic child if they need to use this. For patients who are unable to collect a specimen by masturbation, or for patients who don't have an adequate amount of sperm in the semen, there are some medical procedures that can be done to assist electroejaculation and testicular sperm extraction. And these procedures are performed in the OR under anesthesia by reproductive urologists. Also, for patients who are going to be getting radiation therapy before treatment begins during the simulation procedure, they can have shields made to be placed over the scrotal sac each day of treatment to prevent exposure of the testes to radiation. For females, the standard approach is egg or embryo freezing. This involves about 10 days of hormonal injections, followed by an egg retrieval procedure done under anesthesia. With the advances in technology, egg freezing and embryo freezing really have equal success rates in centers that have experience with this for younger women. And finally, for women who are going to be getting pelvic radiation, they can have their ovaries moved out of the field of treatment. This is a pretty simple laparoscopic procedure. And even for women who perhaps have completed their family building goals, this can actually prevent early menopause, and so may be considered for that purpose as well, not just for preserving fertility. Now, recognizing the importance of this issue to young adults with cancer, a number of professional organizations have developed guidelines in recent years, really highlighting the responsibility of healthcare providers to inform patients of their risks, to let them know about the options that are available, and to refer those who are interested to reproductive specialists. And yet we know barriers persist, and clinicians report that they're not really knowledgeable about the risks and options. They don't have any resources to help them discuss these issues with their patients. They don't know where to refer patients. They're concerned about how costly the procedures are, and they just feel like they don't have enough time to have these in-depth discussions in their busy clinics. And so what I'm going to share with you today is really an approach we used at Memorial Sloan Kettering to help us develop a program, and I'm going to walk you through each of these steps. And obviously we're in a very unique situation. Memorial has a lot of resources that most other centers may not have, and so, but these same steps can work equally well even in a private practice setting. So first, the planning. It's very helpful to start off by establishing a multidisciplinary advisory group, at a minimum including physicians and nurses, but certainly social workers and other healthcare providers like genetic counselors who may be interfacing with these groups of patients you might want to invite to participate. And I know the focus here is on colorectal cancer, but if you're trying to really kind of look at being systematic and improving something within your organization, I encourage you to invite clinicians who work with breast cancer patients, testicular cancer patients, and lymphoma patients, because they're also going to have a lot of experience working with young adults and share the same need for this. And of course, invite some patients to participate. Hearing their perspective about what we did well and what we didn't do so well was really, really helpful to us, and I'm sure will be to you as well. And then you want to take a step back and really do an assessment of what is current practice in your area and what are the unmet needs. And so we did baseline surveys of patients and clinicians. We wanted to know what patients' how satisfied they were with the information they received, and we wanted to know clinician perspectives about how knowledgeable they felt about these issues, what they were doing currently in practice, and the barriers that they had in their own setting. And we were able to do a formal kind of research-based type of survey, but it's equally effective to just speak with people. Go to one of your service team meetings and talk to the clinicians, put this on the agenda for 20 minutes, or talk to some of your survivors when they come for follow-up visits to try to get a sense of what you did well and what you could have done better for the future. And the goal here is to try to identify the gaps in care and what barriers exist in your individual practice setting that you need to address. And you may want to consider designating a single person as a fertility specialist or navigator. So this person can certainly, very importantly, provide the direct services to the patients. You can refer patients to this fertility nurse specialist to do the education and counseling and make the referrals. But this person also might be able to provide services to the organization, helping to develop resources, helping to educate staff, and this is something that we did. I started this role in 2009 at Memorial, and I think having one person kind of really kind of spearhead an initiative is really, really helpful. So then you want to really develop an infrastructure to support the clinicians in implementing this. So you have to have resources for educating patients. The oncologists and the oncology nurses are not going to be expert in this. They need to introduce the issues, but having some written material to really follow up and provide more in-depth information is key. You can certainly create your own, but if you work with reproductive specialists and you have a particular group that you refer patients to, they can write something up for you. And there's established materials out there that are really helpful from ASCO, from the Oncofertility Consortium, American Cancer Society, and Livestrong Foundation. All their materials are really quite good. And then you have to focus on resources for the clinicians. And so there has to be kind of a clearly defined process for how each clinician is going to integrate this into their practice. And it may vary from clinician to clinician. So sometimes I sit down with an individual physician and their collaborating nurse, and we kind of talk about the workflow. A new patient comes in, treatment decisions are made, discussion about risks occur, side effect management is discussed. And so who is currently doing each of those in that practice, and then integrating the risk of infertility and the option to preserve fertility into that discussion. And again, it may look different in individual practices, but people need to feel like they have kind of a defined process for doing this. One thing that can be helpful is electronic prompts or reminders, because people do get busy and sometimes this is forgotten. And so one suggestion is if you have the way to electronically generate a report of all your incoming consultation visits for the next week and highlighting those that are 45 years of age or under. That's kind of the age that we cut off, and that's mostly what you see in the literature. Patient intake forms, you can add a field asking about whether they're interested in having children in the future or whether they're interested in getting information about fertility. In the clinician documentation forms, you can add fields that you discussed the risk of infertility and discuss the options. Again, these are all meant to be prompts to remind you. Some people add the risk of infertility into their chemotherapy consent forms, and some people have added alerts. When you go in to enter that initial chemotherapy order, an alert can pop up to remind you whether you discuss this issue. And then, of course, you need to have someone to refer these patients to once you do have the discussion and they're interested. And so you want to identify local reproductive specialists. These would be urologists, and reproductive endocrinologists for referral if you don't have an organization that has a fertility center or a reproductive urology specialist within your own organization. The American Society of Reproductive Medicine and the Society for Assisted Reproductive Technology both have something on their website where you can search for providers. In addition, there's a relatively new organization, the Alliance for Fertility Preservation, and they're just now rolling out a new tool called Fertility Scout. And with this, you can actually enter a zip code and whether you want sperm banking or egg or embryo freezing, and it will list you kind of like Google with how many miles away it is. It'll list you specialists within your area. And once you've identified some possible reproductive specialists to partner with, you really want to have a dialogue with them to make sure that they are the right group because they're going to meet the unique needs you have. The needs of cancer patients undergoing fertility preservation are very different than the needs of a couple who has been trying to get pregnant for 12 months without success and is now seeking fertility treatment. So it's very helpful if they will commit to giving you a single point person for all of your scheduling. They need to commit to seeing patients within 24 to 48 hours. They need to be knowledgeable about the relevant medical and psychosocial issues that these patients have, and they have to be willing to provide your patients with discounted rates. And then you need to have a clearly defined process for referring these patients. So if this reproductive specialist is within your organization and you already have some kind of online referral mechanism, that's great. But if not, depending on who you're working with, you need to come up with one process that everyone can use, whether that's a phone call, an email, or something electronic. And this Fertility Scout tool that I mentioned, not only can you find reproductive specialists through them, but they also, once you register as a clinician, you can actually do online referrals to these centers. And then you want to create some kind of a library of resources for clinicians. Some key references, for example, the professional guidelines, some key articles on risks and options, some suggested talking points and how to have this conversation, any institutional resources that you have. We created an intranet site. So we have we have one center in the city, but we have actually now we have about 5 satellites within the city, and we have satellites on Long Island, in New Jersey. And so anybody can access this on our intranet no matter where they are at any time. So, I mean, if you can do it that way, that's great. But some clinics prefer, some institutions I know, their clinics have kind of a folder, a paper toolkit with all these resources. So there's no right way. It's kind of, you have to think about where you're working. And then you want to educate your clinicians. And, certainly if you develop some expertise in planning all of this, you certainly can provide that education, or you can invite the partnering reproductive specialists to come in and present. You can invite them to come to grand rounds. If you have disease team or service-specific meetings, you could have them come to one of those, orientations of new incoming fellows and nurses, or you can do something a little less formal, interactive, journal clubs, case presentations, things like that. Now, if you're going to be implementing a fertility specialist or navigator role, you want to make sure that you select the appropriate provider. So a lot of people are interested in hiring an NP or a PA because they can bill. And it would be nice to be able to charge for these services, but you have to remember the focus of the NP-PA role is really to provide medical assessment, diagnosis, and management. And a lot of what we're talking about here is education and counseling. And so, it may be challenging to match those two roles. But if you have NPs or PAs working in a survivorship program, in your urology clinic, or in your gynecologic clinics, it's possible that they could add this responsibility to their role. It depends on their workload, and obviously this is something you have to collaborate within your organization. But if not, another option to consider is hiring a clinical nurse specialist. These are mastered prepared nurses who have clinical expertise and organizational leadership skills. So not only can they provide the education and counseling to the patients, but they can help you develop your resources, do all the staff education, and monitor practice. Or you may just want to have one of your nurses really take on this role, because again, it is fundamentally about patient education and counseling. There's even a center, Northwestern, actually hired a person full-time to do this who was not even a healthcare provider. She was completely trained by her reproductive endocrinology group, and they basically sent her to the oncology clinics to do all of this. So there's a lot of options on how to have somebody kind of designated to take this on. And then you want to implement the program. You want to disseminate information to all your clinicians and kind of schedule a go-live date. And you may want to consider implementing this in one practice or service at a time, especially where there's a high volume of young adults, so that you really can get some experience on some of the things that you've put together. Do they work? What do you need to still tweak? Where are some of the gaps that are persisting? And kind of iron out the kinks before you then spread this out. And we found that it was very helpful to focus where there was interest. And as more and more people got experience and had successful experiences making referrals, introducing this and making the referrals, interest grew. And so, for example, in 2009, 79 patients were referred to me for counseling, and in 2015, about 480 patients were referred to me. And so it grows gradually, and so you want to be patient and let that interest grow. It's very helpful to have champions in your clinical setting to kind of remind people and to be a resource day to day. Once you do implement, it's important to keep in mind that there's going to be challenges in ensuring that the program is institutionalized. That is, that all patients receive the information. So this is something that's the clinician's responsibility to initiate, not the patient's responsibility. And there's going to be continued variation in clinical practice. Some clinicians, with all the education you're going to do, they're going to say to you 3 years in, oh, I didn't know about this program. Some clinicians are going to feel that they should be screening who it's appropriate to have this conversation with. I don't personally share that perspective, but there are clinicians who feel that not everybody is an appropriate candidate. And I really want to emphasize that the whole goal here isn't that every patient should preserve fertility before treatment. The goal is that every patient is entitled to a discussion about their risks and options and to participate in that decision making. And so there's no need to screen who's appropriate because many young people are interested in at least having the discussion. There's also challenges integrating it into the workflow, and also people tend to document this in very different ways, and if you don't have the authority to kind of implement system-wide documentation, that will be a challenge as well. And then the other thing to keep in mind is when you go out and do this education, there's a lot of interest, a lot of people do a really great job, and then there's a kind of a drop-off over time because other initiatives get put in people's faces, and that becomes the new focus. So how do you maintain improved practice over time, not just with your current clinicians, but with new people that come in and maybe miss that initial education? So these are all things you have to consider once you go live. And then finally, evaluation. So one of the things that you could do once you've had the program up and running for a while is you could do another assessment and compare with your baseline, finding out the patient and clinician perspectives of how you're doing now. Also, many of you are probably aware of ASCO's COPI program. This is a set of criteria that cancer centers can use to evaluate the quality of care. Several years ago, they added 2 criteria specifically related to fertility. And basically, the way this program works, it's a review of chart documentation. And so one criteria is that there's documentation that infertility risks were discussed, and the other is that fertility preservation options were discussed. So you could even use those criteria as a way of monitoring practice. And then a final word for patients. Although I would like to think that clinicians would always take the responsibility to initiate these discussions, they may not, and so I really encourage you to ask questions. And so at the beginning of treatment, some of the questions that you could ask are, how will my planned treatment affect my ability to have children in the future? What are my options to preserve fertility before beginning treatment? Is there a reproductive specialist you can refer me to so I can learn more about my options? And after treatment is over, what should I know about my family building options once my treatment is completed? I know that there are a lot of patients in the room, and if you have other more kind of clinical questions, I'm happy to address those afterwards. Thank you.